When 5 to 10 kilograms of distributed weight is placed across your chest, a heavy blanket, a weighted pad, a folded stack of thick quilts, your heart rate decreases within minutes. Heart rate variability increases. Cortisol levels begin to drop. The response begins before you decide to relax, before you slow your breathing, before you attempt any technique. The weight arrives on the chest and the nervous system shifts. The shift is not psychological. It is mechanoreceptor mediated. Ruffini endings in the thoracic skin detecting sustained distributed compression and sending afferent signals through collateral pathways to the brainstem's vagal processing center. The signal your nervous system receives from 5 kilograms of distributed chest weight is biomechanically similar to the signal it received in infancy when a parent held you firmly against their chest. The pathway was calibrated before you could speak. It never degraded. And it activates with the precision it had at 7 months when you place a weighted blanket across your rib cage at 70. You have felt this. If you have ever pulled a heavy blanket over yourself, heavier than you needed for warmth, heavier than comfort required, and felt something arrive that a light blanket does not produce, you have felt deep pressure stimulation activating the vagal pathway, a specific quality of settling, a physical quieting that begins in the chest and radiates outward, the heart rate slowing, the breathing deepening without effort, the muscle tension releasing from the shoulders and the jaw and the hands without any conscious decision to relax. The settling is different from warmth, different from softness, different from the psychological comfort of being in bed under covers. The settling has a weight to it, literally. The nervous system is responding to the mass on the chest, to the distributed compression across the rib cage, to the mechanical signal arriving through the skin and the lungs and the cardiovascular baroreceptors simultaneously. The mass is the signal is mechanical. The response is autonomic, below conscious control, below cognitive engagement, below the racing thoughts that the person may have been trying to escape when they pulled the heavy blanket over themselves. If the response were psychological, if the calm were produced by the idea of being under a blanket, by the association with sleep, by the comfort of the fabric, a light blanket would produce it equally. A light blanket does not. The difference between a 2-kilogram blanket and a 7-kilogram blanket is not psychological, it is mechanical. The heavier blanket activates receptor populations in the skin that the lighter blanket does not reach. The heavier blanket increases intrathoracic pressure that the lighter blanket does not produce. The heavier blanket triggers the baroreflex that the lighter blanket does not engage. The weight is the variable. Everything else, the fabric, the warmth, the bedroom, the intention to sleep is held constant. The weight changes. The autonomic state changes. The relationship is mechanical. Physics of what happens beneath the weight involves 3 vagal pathways activating simultaneously from one intervention. And understanding each pathway explains why the response is so rapid, so reliable, and so independent of the person's mental state. Deep pressure stimulation, sustained, distributed, compressive force applied to a large area of skin, activates a subset of mechanoreceptors that light touch cannot reach. Ruffini endings in the deeper dermis respond to sustained skin stretch and compression. They are the receptors that detect the difference between a hand resting lightly on your shoulder and a firm embrace that compresses the torso. Pacinian corpuscles respond to the initial onset of the pressure, the transient signal that registers when the weight first arrives and the skin deforms. Merkel cells respond to the sustained static component, the ongoing signal that reports the weight is still there, still pressing, still distributed across the surface. Together, these 3 receptor types encode the presence of a heavy, stable, distributed load on the body surface, encoding it continuously, without habituation, for as long as the weight remains. Afferent signals from these receptors travel through the dorsal column, medial lemniscal pathway, to the somatosensory cortex. The cortex registers the weight, maps its distribution, reports its magnitude. But the signals also project through collateral pathways to the nucleus tractus solitarius in the brainstem, the primary integrating center for vagal afferent information. This nucleus receives input from the heart, the lungs, the gut, and the baroreceptors, Every visceral sensor that reports on the internal state of the body feeds into this one brainstem structure, and the mechanoreceptor signal from distributed chest pressure feeds into it too. The brainstem does not distinguish between a weight is on my chest and I am being held firmly against another body. The sensory input overlaps substantially. Distributed compression across the thoracic surface, sustained, stable, covering the full span from collarbone to lower rib cage. The autonomic response is identical, parasympathetic shift. Think about why the brainstem interprets distributed chest pressure as safety. Because the interpretation was calibrated across millions of years of primate evolution through one specific context, being held. When a parent holds an infant against their chest firmly, with the infant's torso compressed against the parent's body, the infant's rib cage receiving distributed pressure from collarbone to abdomen, the infant's heart rate decreases, crying stops, and cortisol drops. This response is present from birth. It does not require learning. It does not require the infant to recognize the parent. The response occurs with strangers, with nurses, with anyone who provides the distributed chest compression. It operates in premature infants born weeks early, in newborns minutes old, in infants across every culture ever studied. The response is to the pressure pattern, not to the person providing it. The mechanism is deep pressure stimulation, activating the vagal pathway through thoracic mechanoreceptors, the Ruffini endings, the Pacinian corpuscles, the Merkel cells in the infant's chest wall, detecting the parent's torso pressing against theirs, and sending the combined signal through the vagal collateral pathway to the nucleus tractus solitarius. Evolutionary logic is direct. Infants who calmed when held tightly were quieter. Quieter infants attracted fewer predators. Quieter infants consumed fewer parental resources, less energy spent soothing, more energy available for feeding, for caring, for the sustained proximity that infant survival required. Infants who remained distressed despite being held, whose vagal pathway did not respond to distributed chest pressure, were more likely to be set down, more likely to attract predators through continued crying, more likely to exhaust parental tolerance. The deep pressure to vagal pathway is a survival mechanism encoded into the brainstem. Pressure on the torso means being held. Being held means proximity to a caregiver. Proximity to a caregiver means protection, and the brainstem reads protection as the signal to shift from sympathetic arousal to parasympathetic rest. Brainstem encoded this sequence before the cortex was mature enough to understand language, before episodic memory began forming, before the infant could distinguish between a parent's arms and any other source of distributed chest compression. The hidden regulators. The mother cell's discussion described heartbeat, warmth, voice, motion, included pressure. Being held was one of the regulatory inputs the infant's brainstem depended on for calibration. The sequence is subcortical. It does not degrade with age. It does not require refresher calibration. The rocking chair discussion described a similar phenomenon. Brainstem circuits calibrated in infancy remaining functional for the lifespan of the organism. The deep pressure pathway operates on an identical principle. A 70-year-old lying under a weighted blanket is activating a brainstem circuit that was calibrated by being held as an infant. The mechanoreceptor input from distributed chest weight is biomechanically similar to the input from being held. The receptor types, the pressure distribution, the coverage area overlap substantially. Whether the brainstem processes them as identical signals or merely similar ones has not been directly compared. The autonomic response to both is consistent. Parasympathetic shift from distributed chest pressure regardless of source. That consistency, the brainstem responding to a weighted blanket the way it responded to being held, is the finding that made the deep pressure literature feel like developmental neuroscience rather than comfort marketing to me. Now, the second vagal pathway. Because the weight on the chest does something to the lungs that produces vagal activation through a mechanism entirely separate from the skin receptors. And the mechanism explains why the person under the weight breathes differently without trying. When weight is placed on the chest, it slightly increases intrathoracic pressure, the pressure within the thoracic cavity that surrounds the lungs and heart. The increase is modest. A few centimeters of water pressure from 5 kilograms distributed across the rib cage, barely enough to notice as a sensation of heaviness on the chest. But the increase is sufficient to compress the lungs slightly, reducing their resting volume. The functional residual capacity, the amount of air remaining in the lungs at the end of a normal passive exhalation, decreases by a small but physiologically significant amount. Each inhalation against the weight requires marginally more diaphragmatic effort. The diaphragm must contract more forcefully to overcome the additional pressure on the chest wall and expand the lungs against the resistance. The respiratory resistance, the wind discussion described from air pressure against the face, occurring here from distributed mass on the ribcage. The person does not perceive this as labored breathing. At 5 to 8 kilograms, the additional resistance is below the threshold of conscious effort, but the diaphragm recruits more fully than it does during unweighted breathing. The contraction is deeper, the excursion is greater, the lung inflation is more complete. Fuller diaphragmatic excursion stretches the lung parenchyma more than unweighted breathing does. Each breath inflates the lungs to a slightly greater volume, stretching the alveolar tissue further. Pulmonary stretch receptors, sensory neurons embedded in the lung tissue that detect inflation magnitude, activate in response to this increased stretch. These receptors send afferent signals through the vagus nerve to the brainstem. The signal is the Herring-Breuer reflex, the respiratory modulation pathway that slows respiratory rate in response to lung inflation. The pathway, the side discussion described from a different entry point. The brainstem receives the signal that the lungs are more inflated than usual, delays the next inspiratory command, and the breath cycle lengthens. Respiratory rate slows. Each breath becomes deeper and slower. The parasympathetic breathing pattern that every breathing protocol in the series has described from a different mechanism. Chest weight produces this breathing pattern automatically. The person does not need to count breaths. The person does not need to extend the exhale deliberately. The person does not need to remember a technique. The weight increases the diaphragmatic effort on each inhalation. The fuller inflation activates the stretch receptors. The stretch receptors send the vagal signal, and the brainstem slows the respiratory rate. The weight breathes for the person, not literally, but mechanistically. It produces the diaphragmatic recruitment and the pulmonary stretch that breathing exercises require effort and attention and practice to achieve. You see. And the third vagal pathway. Because the intrathoracic pressure increase does something to the cardiovascular system that triggers a reflex. The brainstem executes automatically, a reflex that operates independently of the person's mental state, independently of their anxiety level, independently of whether they believe the weight will help. Increased intrathoracic pressure from the chest weight is transmitted directly to the aortic arch. The pressure increase acts on the arterial wall from the outside, pressing on the wall the baroreceptors are embedded in. The baroreceptors in the aortic arch and the carotid sinus. Pressure sensors embedded in the walls of the major arteries that monitor blood pressure with beat-to-beat precision detect the pressure change. The reflex does not require increased cardiac filling. It requires pressure on the arterial wall, and the weight on the chest transmits that pressure through the thoracic cavity to the aortic arch where the baroreceptors sit. Detection triggers the baroreflex, the cardiovascular system's automatic pressure regulation circuit. When arterial pressure rises, the Baroreflex increases vagal output to the sinoatrial node of the heart, slowing the heart rate, reducing cardiac output, bringing the pressure back toward its set point. The reflex is one of the fastest autonomic circuits in the body. It operates within a single cardiac cycle, adjusting heart rate on a beat-to-beat basis. It is automatic. It operates below conscious awareness. It cannot be overridden by anxiety, by worry, by the catastrophic thoughts that the person lying under the weight may be experiencing at 3 a.m. The Baroreflex does not process thoughts. It processes pressure. The weight produces the pressure. The reflex produces the response. The anxious mind is irrelevant to the circuit. The vagal brake engages because the baroreceptors reported a pressure change and the brainstem executed the program response without consulting the cortex. 5 kilograms on the chest activates the baroreflex through a mild, sustained, distributed pressure increase, gentle enough that the person does not perceive respiratory difficulty, sustained enough that the baroreflex remains active for the duration of the loading. Heart rate slows. Heart rate variability increases. The variation between successive heartbeats widens, which is the cardiovascular signature of parasympathetic dominance and the metric that cardiologists use to assess autonomic health. The vagal brake is engaged by the weight itself through a reflex that no amount of anxiety can override because the reflex pathway does not pass through the cortex where the anxiety resides. 3 vagal pathways. 1 intervention. Mechanoreceptor input from the thoracic skin. Pulmonary stretch receptor input from the lungs. Baroreflex input from the cardiovascular baroreceptors. All 3 converging on the nucleus tractus solitarius, the brainstem's vagal integration center, simultaneously. All 3 producing parasympathetic activation. All 3 triggered by 5 kilograms of distributed weight on the chest. Well, and the research confirms what the anatomy predicts. Because the weighted blanket literature, though modest in scale, is consistent in direction. And the consistency across multiple research groups using different populations strengthens the finding beyond what any single study could establish. Akali and colleagues published in the Journal of Clinical Sleep Medicine that weighted blankets reduce sleep onset latency. Subjects fell asleep faster under the weight than without it. The reduction was measurable and consistent across the study population. Mullen and colleagues published in Occupational Therapy and Mental Health that weighted blankets reduced anxiety scores and produced physiological markers of parasympathetic activation. Heart rate decrease, heart rate variability increase, the cardiovascular signature of vagal engagement arriving from the weight rather than from any deliberate technique. Aaron and colleagues published in the Journal of Medical and Biological Engineering that deep pressure stimulation produced measurable decreases in sympathetic nervous system activity across multiple physiological markers. The findings converge. Distributed weight on the torso shifts the autonomic balance toward parasympathetic dominance through measurable, reproducible physiological mechanisms that operate independently of the person's mental state, beliefs about the intervention, or willingness to relax. The studies are small, typically 30 to 60 participants, and the control designs vary in rigor. The direction is consistent across research groups. The magnitude of the effects awaits confirmation in larger trials. What is established is the anatomy. The 3 vagal pathways exist. The receptors are present. The brainstem integration center receives the input. The studies confirm what the anatomy predicts. Optimal weight range in the research is approximately 7 to 12% of body weight. For a 70 kilogram adult, 5 to 8.5 kilograms. Below this range, the mechanoreceptor activation is insufficient to produce reliable vagal engagement. The receptors fire, but the combined signal from skin, lungs, and baroreceptors is too weak to shift the autonomic balance against whatever sympathetic tone the person is carrying. Above this range, the respiratory effort becomes consciously effortful. The diaphragm must work hard enough that the person perceives it as labored breathing, which triggers sympathetic activation rather than parasympathetic, producing anxiety about breathing difficulty rather than the calm the weight is intended to produce. The therapeutic window is specific. For the person over 65 with reduced respiratory capacity, chronic obstructive pulmonary disease, restrictive lung disease, heart failure with pulmonary congestion, or the age-related decline in lung compliance that reduces functional capacity even in healthy older adults. The weight should start at the lower end of the range. 5 kilograms. If tolerated comfortably, no sensation of breathing difficulty, no chest tightness, no anxiety about the weight itself. It can remain or be increased gradually. If the weight produces a sensation of labored breathing at any amount, it should be reduced until the breathing feels effortless. The vagal activation requires the respiratory effort to remain below the threshold of conscious perception. The moment the person notices the breathing effort, The sympathetic system engages and the intervention reverses itself. The weight must feel heavy enough to settle into, but light enough to breathe under without awareness. And here, a fourth dimension, the three vagal pathways do not fully explain proprioceptive grounding. Because clinical observations in anxiety and trauma treatment have documented an effect of deep pressure that operates through somatosensory mapping rather than through vagal activation. Deep pressure reduces the sensation of dissociation, the feeling of being disconnected from the body, of floating, of the physical self feeling insubstantial or unreal. Nighttime anxiety sometimes produces this sensation in older adults. The person lies in the dark and the body feels like it is dissolving into the mattress, the boundaries between self and bed becoming unclear, the spatial sense of where the body ends and the environment begins degrading in the absence of visual input. The mechanism is proprioceptive. The brain maintains its map of the body through continuous somatosensory input from the skin, the joints, and the muscles. In darkness, under a light blanket, with minimal contact pressure and no visual data, the somatosensory input is sparse. The body map becomes vague. The subjective experience is floating, disconnection, a quality of unreality that feeds the anxiety rather than resolving it. Distributed weight restores the proprioceptive map. 5 kilograms across the chest provides constant, unambiguous somatosensory input that the brain maps as body in space in contact with a surface under a stable load. The somatosensory cortex reports contact across the entire anterior torso. Pressure at the collarbones, pressure at the sternum, pressure at the lower ribs, pressure at the abdomen. The body has edges again. The floating stops because the floating was produced by insufficient somatosensory data, and the weight provides enough data for the brain to maintain an accurate sense of embodiment, regardless of whether the eyes are open or closed, regardless of whether the room is lit or dark. And then, the distribution. Because concentrated weight and distributed weight produce opposite autonomic responses, and the distinction explains why a heavy object placed on the sternum feels threatening, while a weighted blanket across the torso feels calming. Concentrated weight on a small area, a heavy book on the sternum, a dense object placed at one point on the rib cage, produces focal pressure that exceeds the activation threshold of nociceptors, the pain-sensing nerve endings in the superficial dermis. The brainstem receives a pain signal rather than a pressure signal. Pain is a sympathetic trigger. The autonomic response is alertness, aversion, the urge to remove the object, the heart rate increasing rather than decreasing. The weight is on the chest, but the response is the opposite of calming because the distribution is wrong. The nociceptors are activated. The Ruffini endings are activated at only one point rather than across the surface. The brainstem interprets the input as injury rather than embrace. Distributed weight, spread evenly across the torso by a blanket, a large pad, or a folded quilt that covers from collarbone to lower ribcage, activates Ruffini endings, Pacinian corpuscles, and Merkel cells across the maximum surface area. The pressure at any single point is below the nociceptor activation threshold because the weight is distributed across hundreds of square centimeters rather than concentrated on a few. No pain signal reaches the brainstem. The signal that arrives is pure distributed pressure, the mechanoreceptor pattern that the brainstem interprets as being held. The distributed pattern is what mimics the infant held against a parent's full torso, broad, even, encompassing, touching the entire anterior surface of the chest simultaneously. Focal pressure is a stone on the chest. Distributed pressure is an embrace. The autonomic response depends entirely on the distribution, and the person who tries this should ensure the weight is spread, not piled. Now, consider the person over 65 who wakes at 3 in the morning. The cortisol-mediated arousal spike that the sleep discussions have described. The HPA axis activating prematurely, producing anxious wakefulness with racing heart and looping thoughts. The person lies in the dark. The heart is pounding. The mind is cycling through worries. Health, finances, family, mortality, the problems that feel unsolvable at 3 in the morning and manageable by 8. The body is in sympathetic overdrive. Cortisol elevated, norepinephrine elevated, heart rate accelerated, muscle tension throughout the trunk, and the jaw and the hands. Breathing exercises the person has been taught require conscious effort. Focus on the breath. Count the seconds. Extend the exhale. Maintain the pattern for multiple cycles. At 3 in the morning, with cortisol elevated and the amygdala firing and the prefrontal cortex barely functional from sleep inertia, the effort of performing a breathing exercise feels impossible. The technique requires the cognitive resources that the anxiety has consumed. The meditation instruction says clear the mind, and the mind is precisely what will not clear. Every technique that requires cognitive engagement fails at the moment it is needed most, because the cognitive engagement is what the anxiety has impaired. The weighted blanket requires no cognitive resources. It was in place before the person fell asleep. It has been activating the 3 vagal pathways continuously throughout the night. The mechanoreceptors reporting distributed pressure, the pulmonary stretch receptors firing with each weighted inhalation, the baroreflex responding to the intrathoracic pressure. When the 3 a.m. cortisol spike arrives, the vagal activation from the weight is already present. It does not need to be initiated, does not need to be remembered, does not need to be performed. The parasympathetic input meets the sympathetic spike with the vagal opponent that was operating before the cortisol surge began. Spike still occurs. The weighted blanket does not prevent the HPA axis from activating, but the spike meets resistance. The vagal tone from the 3 pathways is already engaged. The heart rate that would have accelerated further is dampened by the baroreflex already in operation. The respiratory rate that would have increased is moderated by the pulmonary stretch receptors already firing. The cortisol surge arrives into a body that is already receiving a parasympathetic counterweight from 5 kilograms of distributed mass on the chest. The spike is blunted. The recovery is faster. The person falls back to sleep sooner. Not because the anxiety resolved, but because the vagal pathways attenuated the sympathetic response enough for sleep pressure to pull the person back under. That convergence, 3 vagal pathways activated simultaneously from distributed weight, producing measurable parasympathetic shift through mechanoreceptor, pulmonary, and baroreceptor input converging on a single brainstem nucleus, plus proprioceptive grounding, restoring the body map that darkness and anxiety degrade, is the finding that made deep pressure stop being a comfort measure and start being a vagal intervention with 3 independent input channels for me. The redundancy is what makes the intervention robust. If one pathway were involved, the effect would be modest and variable. 3 pathways converging on one nucleus produce an effect that is consistent, measurable, and difficult for the sympathetic nervous system to override, because overriding one vagal input still leaves 2 operating, and overriding 2 still leaves 1. The weight stacks the autonomic deck toward parasympathetic through sheer convergence, 3 independent signals, all telling the brainstem to shift toward rest. 3 pathways, 5 kilograms, lying still, no technique required, no cognitive engagement. No effort beyond placing the weight on the chest and allowing the brainstem to receive the signal it was calibrated to interpret as safety before the person could form a conscious memory. The intervention is available to every person who can lie down, including people for whom breathing exercises are too effortful, meditation is too abstract, and cognitive behavioral techniques require a prefrontal cortex that anxiety has temporarily disabled. The weight does not require the prefrontal cortex, it requires the brainstem, and the brainstem is always available. And then, the protocol. Lie down. Place a weighted blanket, a heavy folded quilt, or a purpose. Made weighted pad across the chest and torso, collarbone to lower rib cage, covering the maximum thoracic surface area. 5 to 8 kilograms for most adults over 65. If you do not own a weighted blanket, a stack of heavy folded bath towels, 2 folded duvets layered on top of each other, a heavy winter coat spread open across the chest, any distributed weight in the range activates the pathway. The material does not matter. The distribution matters. The mass matters. The coverage from collarbone to lower rib cage matters. The brainstem is responding to the mechanical input from the skin, the lungs, and the baroreceptors. And all 3 respond to distributed mass, regardless of what the mass is made of. Remain still. Breathe normally. Do not try to control the breath. Do not count. Do not extend the exhale deliberately. The weight will do the work. The diaphragm will recruit more fully against the resistance without your awareness. The pulmonary stretch receptors will fire with each inhalation without your participation. The mechanoreceptors will send the distributed pressure signal continuously without your attention, and the baroreflex will respond to the intrathoracic pressure change without your permission. The vagal pathways do not require your cooperation. They require the weight. Within 5 to 10 minutes, the heart rate will have decreased. Measurably, consistently, through a reflex the cortex did not initiate. Heart rate variability will have increased. The beat-to-beat variation widening as parasympathetic tone rises. The breathing will have deepened and slowed without any conscious effort to deepen or slow it. The muscle tension in the shoulders, the jaw, and the hands will have released. The sympathetic drive that was holding those muscles contracted, softening as the vagal output increases. The settling that arrives is not relaxation in the psychological sense. It is 3 vagal pathways activated simultaneously by distributed weight on the chest, producing a parasympathetic shift through brainstem circuits that were calibrated by being held before the person could form a conscious thought about what was happening. The weight is not therapy. It is physics. Pressure on skin, stretch in lungs, compression on vessels, 3 signals converging on a brainstem that was calibrated by being held and has never forgotten what that pressure means.